Well, a very good morning to you all. The first session of this, what promises to be an important ESC conference. This is a session on telehealth, for whom, when, and how. We have three speakers, two about heart failure and one about hypertension. My name is Arno. I work at the University Medical Center in Utrecht in the Netherlands, and my co-chair is Simone INKROT from Charité in Berlin. So let's kick off with the first speaker. Let me say before we start that, although this could be a test whether the chairs could think of any questions, there's lots of people in the room who are certainly experts, I guess, so we expect a lot of questions from the audience. The first speaker is Dr. Köhler from Berlin, and he will be talking about telehealth, not for every patient with heart failure. Please, Dr. Köhler.
Good morning, ladies and gentlemen, dear chairman, dear colleagues. Telehealth, not for every patient with heart failure. Over the last 2 decades, the prognosis of heart failure patients improved enormously. As a result, the incidence of heart failure patients is increasing constantly and requires huge economic resources. In Germany, the annual costs for heart failure patients are approximately 3 billion euro. Since 2005, heart failure is the main reason for any hospitalization in Germany. Almost 200,000 patients from the 1.2 million German heart failure population are hospitalized due to heart failure every year. And this requires more than 85% of the heart failure budget. Vice versa, 5 out of 6 patients who are not hospitalized require only 1/5 of the budget. As a consequence, better strategies has to be found to increase the number of patients who could be treated out of the hospital. There are strong expectations that telemedicine could be a promising facet for such heart failure programs of the future. The principal idea of telemedicine heart failure is A, the early detection of any deterioration by daily measurements of vital parameters, followed by an early intervention. Moreover, B, in a stable phase of the disease, any intervention could be monitored, for example, the up-titration of drugs. For the early detection of deterioration, the patient in telemedical care programs have to use specific sensor devices, which can be divided in a non-invasive or invasive approach. In the non-invasive telemedical approach, the telemedical devices allow to measure weight, blood pressure, and so on. The advantage of this approach is that the setting can be individualized to the individual requirements of each patient. For example, to monitor comorbidities, diabetes, COPD, beside heart failure. In the invasive telemedical approach, the detection of early deterioration is based on hemodynamic measurements derived from implanted devices. Beside the categorization of the invasive and non-invasive sensor approach in telemedicine, it is important also to classify the type of generation of the whole telemedical systems. One categorization of generation typing is based on the flow of information. The data flow is divided in an afferent way from the patient to the telemedicine center and into an efferent way from the telemedical center back to the patient. One can define 4 different types. In the systems of the first generation, there's only an automatic transfer of data to the doctors via SMS or email or any other technology. This may cause a delay of information because, fortunately, all doctors are not 24 hours, 7 days a week in charge. The system of the second generation overcome this disadvantage due to a telemedical center which analyzes the incoming data from the patient, but the afferent way to the GPs or treating cardiologists is using also SMS or email, facing the same problems as systems of the first generation. The characteristics of the third generation systems are telemedical centers which are working 7 days, 24 hours with a staff of doctors and nurses. These telemedical experts are able to react on demand, especially during night times and bank holidays, for example, to adapt diuretic therapies. The fourth generation telemedicine covers different diseases, including comorbidities, and allow much more complex telemedical intervention, for example, the monitoring of peritoneal dialysis in end-stage heart failure. Over the last 2 years, 4 relevant randomized control trials focusing on remote patient monitoring in heart failure were published. The TeleHF study and the TIMHF study for the non-invasive strategy, and the Champion study and the DOT-HF study for the invasive strategy. Additional studies are ongoing or in preparation. A useful matrix to analyze the different RCTs for telemedicine in heart failure can be based on 4 categories. A, the characteristics of the included heart failure study population. B, the teletechnology generation used in the study. C, the follow-up period. And D, the primary endpoint. The Telehealth study was one of the largest telemedicine study ever done, including 1,653 patients discharged after hospitalization not longer than 30 days. The device used in the trial was the first generation system consisting in an answering machine for self-assessment of vital parameters, including questionnaires, which was combined with a data bank system. The follow-up period was 6 months. The study could not show a benefit in the primary endpoint for the rehospitalization or death of any cause for the intervention group. The TIMHF study. In the TIMHF study, the patient population was different. The study was one of the longest telemedical studies, mean follow-up 26 months, including 710 stable heart failure patients with a heart failure hospitalization maximum 2 years prior randomization. The intervention consisted in a 24/7 complex remote telemedical patient management using a telemedical system of the third generation. The primary endpoint was total mortality. There was no difference between usual care group and interventional group in the primary endpoint. A subgroup analysis could identify a specific target group of heart failure patients for whom telemedical care could be beneficial. Patients with ejection fraction over 25, heart failure hospitalization not longer than 9 months prior intervention, no symptoms, this was surprising, of depression, might benefit in terms of cardiovascular mortality and in a lower number of days lost due to heart failure hospitalization or death. The conclusion from the TIMHF study are clear like a crystal. Stable patient treated following the guidelines and without a heart failure hospitalization longer than 12 months do not need telemedicine. There will be a TIMHF 2 study upcoming soon by the end of this year to investigate the effect of telemedicine in the study population or the beneficial study population of TIMHF1, including 1,500 heart failure patients, and this slide shows the differences in our metrics viewing criteria about telemedical studies mentioned above between TMHF1 and TMHF2. The Champion trial investigated the invasive telemedical strategy. In this trial, 570 class 3 patients hospitalized for heart failure within the past 12 months underwent an implantation of a pulmonary pressure device with a daily transfer of data of the pulmonary pressure and in a control group without data transfer. The intervention was the adaptation of the medication based on the transferred hemodynamic data in a third-generation setting. The mean follow-up was 15 months, at least 6 months for every patient. This study showed a significant benefit in the primary endpoint rate of heart failure hospitalization. The Champion trial is the first positive trial in the heart failure patient since the landmark trial 10HMS by John Cleland. The study was underpowered for the endpoint mortality, and the process to get an FDA approval is ongoing. In the .HF study, 335 class 2 to 4 patients underwent an implantation of an implantable cardioverter defibrillator plus intrathoracic impedance tool with an audible patient alert when crossing pre-specified thresholds. In the control group, the data transfer and the audible alerts were blocked. The mean follow-up was almost 15 months, at least 5 months for each patient. The primary endpoint was all-cause mortality in heart failure hospitalization. And the study could show no benefit for the intervention group in terms of the primary endpoint. Audible alarms caused by crossing intrathoracic impedance threshold increase the rate of heart failure hospitalization outpatient visits. The study was terminated pre-terminally due to slow enrollment and after futility analysis. Ladies and gentlemen, may I summarize? Telemedicine for whom? To our knowledge now, this is good. Telemedicine is good for heart patient class 2 and 3. No need for 1, maybe too late for 4. And second criteria, recently hospitalized, not longer than 12 months. And these patients benefit in terms of mortality and morbidity. Stable patient with no hospitalization, good treated, and no hospitalization over 12 months do not need telemedicine. Telemedicine, how long? Telemedicine could be a bridge to stability for heart failure patients recently hospitalized. The goal should be an event-free year from heart failure hospitalization for 12 months. As a consequence, telemedicine should be not longer than, in this intensive way presented in the studies, should not longer last than 1 year if this goal is achieved. There is no evidence at this time for a need for lifelong telemedicine. And the exit from this intensive telemedicine after a successful year or event-free year should be included or accomplished by self-empowerment strategies. The patient should use their devices, but they not be connected on a 24-hour basis to a telemedicine, and they had to learn by ourselves. Telemedicine, how? Telemedicine, as shown, includes different technology, concept, and settings, which is one of the reasons for different RCT outcomes. The search for an optimal sensor, may be invasive or non-invasive, I think both is the final answer, will be the final answer, is still under investigation. Besides this, it is very important also to focus on the generation of the telemedical setting as a whole, and I think the third generation system should become more and more in charge. As a consequence, overall, the terminus telemedicine could be or should be maybe replaced to a terminus remote patient management, I would suggest, which include the telemonitoring from the home of the patient, the activities of the tele-nurses, including education, including home visits and any other things, and but last but not least, the very important rule of the structured outpatient visits from the GPs and from the cardiologist. Telemedicine is not a competitor to GPs or cardiologists. It is a part of the net. The title of was not so optimistic, not for everybody. I will close my presentation that we can expect new evidence about telemedicine heart failure within the next 3 years when ongoing studies are completed. Thank you very much for your
Thanks very much, Dr. Köhler, for a very good overview. Now it's up to you, audience, to ask questions. Please make yourself known and then ask the question.
Good morning. My name is Rot, and I'm from Israel. I was listening very carefully to your talk that was very interesting, and I'm happy that you concluded with an optimistic thought. Although the results you have shown us were not very optimistic. What I would like to say are two things. First of all, you know, this paper in the New England, they spoke only about telemonitoring. They didn't say one word about management. So what's the big deal of telemonitoring if nothing follows? So this is not clear to me. This is one. Second, I think that to look only on mortality is not correct. How about quality of life? How about going back to work? How about many other things? And I think that there are clinicians that will agree with me that even if your life is not prolonged, but your quality of living is improved, that gives a lot. And quality of living, I think, prolongs life. Question is only how to make the statistics. Thank you.
Yeah. First, I absolutely agree with you. The point is, that's why I also suggested a change in this terminus telemonitoring, switch to remote patient management. The key element is not to send everyday data. The key element is what will happen with this data, and it is the intervention. And this is also, even in the Champion trial, was not clear outlined. What is it doing? What are you doing with the elevated pulmonary pressure? What is a SUPs to do that? And I think this structure and to do this interventional aspect is much more important in the upcoming study and should be clearly outlined. Monitoring to send data is not the answer for the future. Second, primary endpoint or appropriate endpoint in studies. I absolutely agree with you. For Telemedicine, it was maybe a mistake to use the total mortality, because the heart failure mortality now it was less than 40% of the total mortality. This is not at this moment an appropriate endpoint. But I cannot, we must also see in different, when we think about the future, we had to show to our health insurance companies evidence, and nobody pay at this moment in time for better life, quality of life. And to come in the real world, it is necessary to show evidence that, for example, an appropriate endpoint would be, or we think about is, keep the patient, or the mission is, keep the patient alive and out of hospital with a good quality of life. And that's why appropriate could be days lost due to heart failure, hospitalization, or death as the appropriate endpoint for upcoming trials.
Okay, there's room for one more question.
Good morning, I'm Marcelo Katz from Brazil. My question, adherence to medications is a very huge problem we are dealing with. And my question, if in your opinion, what's the most important intervention with the telemedicine? Is it the monitoring and changing the medications, or the education? that help with compliance of the patients to the medications. I believe in the second one, and if the second one is most important, if the second one is the most important, I think perhaps it's not so complex to do telemedicine. Perhaps if we invest in programs of education and help patients to compliance with the medication, I think we'll have better outcomes. What do you think?
I think both is very important. A man who is standing on the scale every day, he also usually took also his drugs. It gives him structure, and he gives also at least 1 second a day he think about his disease. This I agree. This is a very important point, and we think in good thing we have a high rate of compliance in medical studies. This is not a problem, but on the other side, I really believe or we think that you need this potential of a daily monitor, to have a daily to use also to reach targets in guideline therapy, to come up titrate that. You say, okay, I have a target should be heart rhythm in rest under 75, and I do it by beta or anything else, and the most threat of the GPs is fear of the GPs is too high, and there could be side effects, and they said we have the monitoring to do that. And the other point is, it seems that the technology is so important in that. It's not so doing, and we have half of the audience has an iPhone in the pocket, and I think we are talking with the industry to use the TVs, or to make it very easy and also very cost effective, is that the devices can be at home, but the key point and the cost effective is how to then connect it in a for example maximum 7 days 24 hours setting. But when we have reached target, then we can do it. The devices stay at home, but the cost driver are these services. And we should select on high-risk patients.
Thank you. Thank you very much. We go on to the next speaker.
Dear colleagues, it's my honour to introduce our next speaker, John Cleland, who is Professor of Cardiology at the University of Hull, and he will speak about telemonitoring as a valid tool for patients with heart failure. Professor Cleland, thank you.
Well, thank you very much for that introduction. I think you've just been described telemonitoring as a glass half empty, and I'm going to try and describe it as a glass 3/4 full. So I believe that telemonitoring will become a standard part of care for most patients with heart failure within the next decade. And I think the big issue is not if this is going to be done, it's just how it's going to be done, and whether this is going to be within 2 or 3 years, or whether it's going to take 7 or 8 or 9 years. It may require different approaches or technologies depending on the patient's risk profile, depending on the geography, and I notice that Professor Köhler is going to be looking at the use of telemonitoring in rural versus urban areas, and I think this is very important. And of course, when it comes to places like Australia and Canada, where there can be vast differences between the care centre and the patient, geography really can become important. And also the healthcare system, that telemonitoring may operate very differently in the United Kingdom with the National Health Service compared to a private payer system. So I would agree with Professor Köhler that it's not for every patient, but perhaps almost every patient. So I'm going to start off with a true story. For those of you who don't know this character, this is the Professor of Pharmacology at the University of Cambridge. He's one of the brightest and best amongst the clinical academics in the UK. And I had the privilege of flying back with him one time from America after the American Heart Association to Heathrow. But Heathrow, unfortunately, often at that time of year, got fog-bound, so the plane was diverted to Stansted. Now, Stansted is right next to Cambridge, so Professor Maurice Brown, being an intelligent man, decided that it would be a good idea if he got off the plane at that time. But if those of you who have been in this situation know that the airline company usually likes to fly you back to the fog-bound airport or put you on a bus and take you back to the fog-bound airport where they then release you. But of course that was going in exactly the opposite direction from what he wanted. So this is back in the late 1980s, and he was the only man on the plane with one of these. with one of these. This was his mobile phone. This was the approximate relative size of his mobile phone to him. We were flying business class, and he was the only person with a mobile phone in the whole of this business class lounge. And he pulled this out, at which point the Sky Marshal, with his gun, said, "What are you doing with that thing?" and put it away. And, this was the reaction to mobile phone technology 20 years ago. So I think we've moved on a bit from then. So how does telemonitoring work? Does it work by magic? I'd like to think it doesn't. Is it a fiendish new risky invention? Probably not. Is it the new secret weapon in healthcare? Or is it just another better way of organizing stuff? And those of you who followed the Olympics will know that the certain teams were worried about the wheels on the British bicycles, and that there was something magic about the British bicycle wheels, but the British team just insisted that they had exceedingly round wheels, rounder than anybody else's, and that round wheels were a good thing on a bicycle. So perhaps it's just a better way of organizing stuff. And heart failure is complex. Most patients are on 5 or more cardiac drugs, which or most of them need individualized dosing. They're also on many non-cardiac drugs. There are complex and changing needs as renal function changes, as blood pressure changes, as heart rate changes and heart rhythm. All of these need to be monitored, and we need to adapt our treatment to these changing circumstances. And that requires monitoring. And if you're like the US or the UK, increasingly the payer or the government is looking for evidence that you're actually delivering an appropriate level of care. So not only have you got to do the right thing, you've got to be able to show that you've done the right thing. And this requires appropriately trained staff, for sure, but it also requires an organizational framework. And perhaps the great thing about telemonitoring is that it's a systematic organization of care and everything gets documented. So there's some good uses for telemonitoring. That's organization of care. It's communication, so it reduces the need to wait for an appointment for a patient who's got a particular concern. I think it's low cost. We should remember, at least in North America and Western Europe, that our huge healthcare cost is not on hospitals. It's not on PET scanners or CT scanners. It's not on drugs. It's not on defibrillators. It's not on coronary bypass. It's actually on staff. It's doctors and nurses and the staff in the health service that actually cost so much money. So if you're investing so much money in the staff, you've got to make sure that your staff are as effective and as efficient as possible. And this isn't about people losing their jobs, I think, because the big problem that our governments are facing is the rising number of older people in the population, and we're going to, unless we make our staff more effective and efficient, we're going to have hugely increased numbers of doctors and nurses. So how do we manage this rising problem without an equivalent increase in the number of staff? And telemonitoring potentially is one way. I'll get on into the concept of health maintenance in a moment, but I think that's very important. Patient education has already been said. Getting the patient involved. We have the largest workforce out there are actually the patients. Now, what can the patients do to contribute to their health care? They can take their tablets, and indeed there was one Hyde Park Corner session at the Heart Failure Society of America a few years ago when it was suggested that the government should pay patients to take their tablets, and if the patient could prove they'd taken their tablets, they would actually get money from the government for doing so, and that was felt to be potentially cost effective. And of course, if we're going to be looked at by government to make sure that we're delivering the quality of care we're supposed to, then telemonitoring with its information systems is a great way of audit. We've also got the lesser uses of telemonitoring, but it's in fact these lesser uses that have dominated the picture of telemonitoring in this first decade. It's trying to predict who's going to run into a crisis and manage the crisis, but the huge problem with that is false alerts, that you get so many false alerts that eventually the nurse says, well, nothing ever happens when this goes off, and they just get irritated with the system and switch it off. But there's a problem with this lesser use. It's a form of voyeurism, because you're actually maybe watching a patient, watching them deteriorate, and then say, only once they've crossed a certain threshold of deterioration am I going to intervene. And I would say that this voyeuristic aspect of telemonitoring is one that's failed. I'm involved in a European Union FP7 program called Heart Cycle, and this is trying to shift the concept from crisis detection to health maintenance. If you think about it, the crisis detection approach to telemonitoring is trying to navigate on a dark and foggy night with one of your headlights not working this coastal road, and you can see it looks pretty dangerous in places. What the health maintenance approach tries to do is move the road a couple of miles inland and put on some decent lighting and road marking and make things much safer. By the time you get close to the cliff edge, perhaps this is not the optimal time for intervention. And trying to maintain somebody in a health maintenance envelope, so this is not about trying to detect who's deteriorating, this is trying to keep people in the optimal medical state. It's much more optimistic. I think it engages and motivates patients much more. Rather than waiting for something to go wrong, it's how do we get things to be as right as they possibly can. Leads to more active management. I think it keeps the nurses and the doctors who are involved in telemonitoring to pay more attention. It also allows us to calibrate the patient. We can use these systems to say, well, how much tolerance has this patient got before something bad really happens? And it addresses the issue of false alerts, because false alerts are no longer that relevant because you're actually actively managing the patient. And of course, we need a personalised care plan, because one of the other great things about telemonitoring is it's not one size fits all. You can titrate the treatment much more effectively for the individual patient need. So I think the first era of telemonitoring is over, and it's time to move on from crisis detection to health maintenance. And we should remember that telemonitoring is greater than the sum of its parts. If you try and dissect telemonitoring into its individual components, you will find that each of those individual components is weak and will probably fail unless you have an enormous clinical trial. But you put all the elements of telemonitoring together and combine, they're a very powerful weapon. It is an information system, so an information retrieval system. It's a way of managing and investigating your data and actually having intelligent systems that can help the doctor and the nurse understand what to do. I think it's also about the patient engagement and experience and educating the health professional. And it is, as one of the audience suggested, it's changing the treatment that changes the outcome. Just watching a patient deteriorate isn't going to change anything. It's what you do in response to the information. You've seen some of the data presented so far, and I'll just briefly represent some of it. Professor Köhler didn't show the Cochrane review. This is the Cochrane review of structured telephone support and the impact on all-cause mortality. And you can see there's an interesting trend with about 5,000 patients in these clinical trials, but not quite statistically significant on conventional boundaries. If we look at all-cause hospitalisation, doesn't seem to be any doubt that very simple picking up the telephone on a regular basis, just checking things with the patient at home seems to have an impact on hospitalisation. If we go for physiological home monitoring, so this is now engaging the patient a bit more, getting blood pressure measured, heart rate, heart rhythm, weight, you can see, interestingly, and this is a consistent story across telemonitoring studies, is this reduction in mortality, and a 34% reduction in mortality, which is quite substantial. Numbers of patients are not so large. It's only 2,700 patients so far in the Cochrane analysis. If we look at the impact on hospitalisation, it's much smaller than the impact on mortality, interestingly. Now, you've seen these studies mentioned already by Professor Köhler. This is the 10HMS study. I was the PI of this study, started about a decade ago. You can see that the best performing group, at least initially, were the telemonitoring group in red, but the next best performing group was the nurse telephone support. So the nurse with the telephone phoning up the patient, trying to make sure they're taking the right medication, etc. What's interesting is that when you put the total costs of these two interventions together, it was actually the nurse telephone support was more expensive than the telemonitoring, because there were more office visits, more home visits, more driving, more staff time was consumed by the nurse telephone support, and the more technically complicated intervention actually worked out less expensive. So there is an issue about efficient use of staff and remembering that it's the people in the health service, at least in Western Europe and North America, that are the dominant cost. TeleHF I wouldn't regard as a telemonitoring study at all. The compliance with the voice interactive system was very low. It really, for me, this at best is a telephone support system, not really a telemonitoring system. TIMHF, I think in many senses, was the gold standard intervention amongst clinical trials. The trend was positive, and in fact, when you add this to the Cochrane analysis, it makes no difference. It's still a highly significant reduction in mortality and hospitalisation. One of the things to note, and I think this is an important issue that Professor Kohler brought out, which is that the rates of events, these are the rates of events in 10-HMS in a group of patients who had chronic heart failure, who had an episode of worsening heart failure, and who were then discharged into usual care, specialist advice, but the primary care physician was asked to deliver the treatment. And this is what happened, and this is when you added nurse telephone support and the home telemonitoring. You can see quite a dramatic reduction, but still by 15 months, very high rates of events. These are, at 26 months, the rates of events in TIMHF and another telemonitoring study, THAF. If you go for stable patients, you are going to see lower events, and therefore you need larger trials in order to show impact. And this is the larger trial. This is the whole system demonstrator published in the British Medical Journal 2012. This is a cluster randomised trial of 177 general practices, and there are problems with cluster randomisation. This is where you take a general practitioner and all his patients and randomise them to one strategy, and another general practice the patients get randomised to the other strategy. So you're randomising clusters of patients rather than individual patients, and there are problems with that. Also, they took a very broad group of patients they had to have at least one of these three conditions, and most of the patients actually had two of these medical conditions. You can see that only about a third of these had heart failure. I should point out that if you don't have heart failure and you have COPD or diabetes, your annual mortality is less than 3%. Whereas in the community with heart failure in the UK, in an elderly population, you're still talking about a 10 to 15% annual mortality. This is the impact on admission or death, highly significant, and again showing up a reduction in overall mortality with telemonitoring. This is the absolute reduction in mortality, and you can see it's about 4%, which when you look at trials of antiplatelet therapy or angioplasty after a myocardial infarction, this is about twice the effect size of these things that we think are a standard of care in cardiology. So pretty substantial effects. So when you add this to the Cochrane analysis, you come up with a really rather, well, why are we not doing this type of conclusion rather than should we do it? Technology differs. The telephone support, including voice activation, seems not so good. Physiological telemonitoring does seem to be effective. It's not clear whether we can just go with the non-invasive or whether we need invasive technology. We should be aware that care usually improves if it's the focus of attention, and I think one of the problems that Professor Kohler had in the TIMHF study was that German physicians are actually rather good at managing heart failure, especially when they know the patients in a clinical trial, and I suspect the care in the control group in TIMHF, well, I know the care in TIMHF in the control group was far above the standard achieved in most countries. So if you're making it very hard for telemonitoring to work under those circumstances, if it's the most cost-effective thing to do just to invest in the doctors to produce good quality German care in the control group and that is the best solution and the lowest cost, then that's fine. But maybe telemonitoring is actually a wiser way of making your highly trained staff more effective and more efficient. I think there's also a problem with lack of integration into existing services, and I think the cluster randomization of the whole system demonstrator in the UK to some extent overcomes those sorts of concerns.
Sorry, I can see people wanting to ask questions. Sorry.
Okay, so well, I'll just wind up with one or two. We should remember on all of this that we need to get the patient more involved, and 70% of care decisions, I think, should be made by the patient, supported by a system that's there to give the patient advice. So I think this is going to be the future. We've got all sorts of technologies. We've got ingestible systems. We've got wearable systems with radar. We've got implantable systems in the pulmonary artery. And the latest that we're working on are tattoos. So you can actually tattoo circuits into the skin, and with an iPhone or some similar reading, you can get blood sugar, sodium, urea, maybe potassium. So this is a very exciting development. So in conclusion, I think telemonitoring is going to become a keystone for quality care in heart failure and many other chronic diseases. Use it flexibly, as Professor Kohler has suggested. There are times it should be applied more intensely and less intensely, and that will depend on many factors. And I think that telemonitoring has gone beyond its infancy and it's now in its adolescence. And as we know, adolescents have their problems, but they are the future. Thank you.
Thank you very much, Professor Cleland, for the very convincing lecture that the glass is indeed 3/4 full rather than half empty. And we have time for one question.
Professor Cleland, thanks for your talk. I'm Anna Banerjee from Birmingham, England, and I wanted to know that since so many of the patients in the trials have multiple diseases, have comorbidities, and you're asking for this integration, do you think that's the way we should be delivering telemonitoring, or should be trialling it in the future across diseases rather than targeting one disease?
To be honest, I think that within 20 years, by the time you reach 60, you will have some sort of remote management support in your home, whether you're sick or not. So I think it's happening, and I think you already see it with some of the iPhone applications. And there's, the big issue is the worried well, and how are we going to manage their expectations? Because the technology is going to be out there, people are going to use it. I think that the great information is power, and the patient to be able to know that that information is readily available, readily retrievable. You've worked in the UK NHS, I think, and you have probably worked there 10, 15 years ago, and you know what it's like. The patient turns up at outpatients and the results are not in the notes. It can take you half a day to find them. By having information retrieval systems and telemonitoring and information, electronic patient records, information systems, they're all hitting the same target. These are not different things, these are the same thing. This is about transferring information, gathering information, sharing information, involving the patient as part of, as a caregiver. And so, yeah, I think it won't matter what chronic illness you've got, you will have some sort of remote support at home.
Right. Thank you very much. I'm afraid there's no time for additional question because we have one additional speaker. We'll switch from heart failure to hypertension now, and telemonitoring self-management of hypertension in primary care. And the presenter is Professor Richard McManus, who is Professor of Primary Care at Oxford University in the UK.
Good morning, everyone. Thank you, Arno.
Leland now, but I hope you survive.
I think that's probably a compliment. So, over the next 15 minutes or so, I'm going to talk to you a bit about the rationale for telemonitoring and self-monitoring in hypertension, then to go over the results of a trial we've done combining telemonitoring with self-management for patients, and then look at how that might fit into care. So if you're going to get someone to telemonitor in terms of their blood pressure, you need to get them to self-monitor to start with. And this has been going on for much longer than many of you may realise. In 1930, a patient turned up at the Mayo Clinic. I like to think this was the precursor of the patient turning up with an internet printout. They were described as a 25-year-old intelligent male who'd monitor their blood pressure for 3 years, 3 times a day. And when they got over their shock that someone had been doing this, they had a look at the readings, and they found that the blood pressure had varied with the man's diet, with the seasons, and the blood pressure went up at the weekend, which was put down to the diversions of a young man, which I'll leave it to your imagination what that might have included. So the first trials of self-monitoring started in the 70s, and initially this kind of work relied on sort of fairly basic kit, which was fairly tricky to use and needed some training on the patients. But over the last decade or so, there's been electronic monitors available, which are really pretty accurate and make life a lot easier. And we know from surveys that now in the UK, about 1/3 of patients with hypertension in primary care are self-monitoring. In the US and the rest of Europe, it seems to be higher, particularly in specialist settings. Interestingly, we also know that about half of the people that self-monitor don't ever tell their physicians that they're doing it. We surveyed last year just over 600 general practitioners in the UK, and about 90% thought that they had patients who self-monitor. And most of those primary care physicians were using self-monitoring for management of hypertension rather than for diagnosis. And in the UK, at least, telemonitoring isn't widely available. In terms of self-monitoring, what are the effects? Well, overall, systematic reviews suggest small but significant reductions in blood pressure. However, if you compare self-monitoring on its own, which is on the right here, relatively small benefits which are presumed to be due to improvements in lifestyle and adherence to medication, whereas if you add self-monitoring to another co-intervention, then rather more impressive results happen. So what kind of things can you add in for self-monitoring? Well, telemonitoring is one, the topic of this morning's session. Self-management, which I'm going to be talking about in a minute, and the other kind of things you can do, very similar to, as you've heard from heart failure, nurses ringing patients and getting involved, or patient education, again, doesn't necessarily need to be nurses, but improving education and using self-monitoring as a tool for that. So in terms of telemonitoring, what might be the attractions? And again, there's a lot of overlap here between hypertension and heart failure. Feedback to the physician, or the GP in this case, gives the opportunity to intervene. It promotes the doctor-patient relationship and hopefully means that the half of people who aren't currently telling their physicians that they're monitoring can actually share some of this data. It allows blood pressure to be monitored much more frequently than the intermittent, perhaps 3 or 6 month visits that are more likely. You can have automatic feedback, for instance, for very high or very low readings to get alerts and things to happen quickly. Potentially it can reduce carer burden for those people who need to be taken backwards and forwards from the clinic. As we've seen, there's the potential for better control than self-monitoring on its own. So what about self-management? Well, we know from other fields such as arthritis and asthma and diabetes that patients have been self-managing for some time, particularly in things like diabetes, very common for people to adjust their own doses of insulin. In hypertension, it's rather different from these types of conditions because there aren't really symptoms in the vast majority of patients unless the blood pressure is incredibly high. But we know that clinical inertia is very common. In other words, those of us who are physicians, probably less than half the time when we measure a blood pressure that's above target do we do anything about it. Now, one small study of around 30 patients followed up for 3 months suggested that self-management might be effective. However, this wasn't really enough evidence to change anything. So we set out to find out whether self-management was possible on a rather larger scale. And our research questions were, did self-management with telemonitoring and titration, self-titration of antihypertensives in people who started off with poorly controlled blood pressure result in better control of blood pressure, changes in adverse events, health behaviours or costs, and was it achievable and acceptable? So we randomised patients aged between 35 and 85 who had a diagnosis of treated hypertension and who at baseline were taking no more than 2 antihypertensive medications. That was basically to allow some room for manoeuvre. At baseline, their blood pressure had to be above 140/90, and they clearly had to be willing to self-monitor and self-titrate. And they were individually randomised to our intervention or usual care by their general practitioner. And we stratified that randomisation by practice, minimised on sex, baseline systolic and diabetes status. Throughout the trial, the practice general practitioners determined the overall management plan, and that's important. We didn't force them to use any particular drugs or any particular regime, although we did make sure that they all had information about the latest UK guidelines. And the system we used was to get the patients to measure their blood pressure twice each morning for the first week of every month. And they used a pretty standard on monitor here. And this was attached via a modem which went into a standard telephone line. We started this in 2005, and at that stage, not enough of the patients had mobile phones for us to use a mobile phone system. This was basically a dial-up internet connection which sent results to the trial database, and we sent summaries every month to the GP. And over the course of a year, this is what a set of readings would look like. Each of these sets of blue bars is a week's readings in the first week of every month. This is just the heart rate. And rather similar to one of the diagrams that Professor Cleland has just shown you, we had a system where with different levels of intervention, where red meant either a very high blood pressure or a very low blood pressure where action was needed fairly urgently. Amber was an action point where if blood pressure remained at this level, it triggered the patients to do an intervention. And green was carry on, your blood pressure's all right. And we adjusted our home blood pressure targets to take into account the fact that blood pressure measured at home or indeed on ambulatory monitoring is lower. And at that stage, the standard in the UK was to take off 10/5. At the beginning of the trial, patients agreed a titration schedule with their general practitioner, where they basically agreed some medication changes, which could either be adding new medications or increasing current medications, should their blood pressure be in the amber system. Every time they had made 2 changes in their medication, we asked them to go back and see their GP to get another 2. And this was a fairly conservative system because this hadn't really been done on a big scale, and we were concerned if we gave them lots of changes that we might lose control of what was going on. We followed up patients independently at baseline 6 months and 12 months, and our main outcome was systolic blood pressure, with secondary outcomes that are there. And our target was to recruit 480 patients, which we thought would allow us to detect a 5mm difference in systolic between groups. We had an embedded qualitative study where we did interviews of patients covering things like knowledge and understanding of blood pressure, experience of the trial, and their preference for self-management. These were done with standard qualitative methods, taped and transcribed and analysed by the constant comparative method. So we managed to recruit more patients than we needed to, which was largely due to my paranoia that we wouldn't get enough. And about 80% of the patients in the intervention group were still self-managing at the end of the year. And we followed up 91% of patients. We lost 9% that we couldn't persuade to come to the follow-up. And our baseline demographics suggested that our randomization had worked and that both groups were fairly similar. Patients were in their mid-60s, pretty much 50-50 men and women, and baseline systolic was 152 over 85. They were mostly white, they were mostly slightly overweight, and you can see the others there. On average, they were taking 1.5 antihypertensives. And our primary outcome in terms of systolic blood pressure was significantly reduced in the intervention group compared with the control, both at 6 months and at 12. And in terms of why this happened, it appeared to be better use of medication, as we've heard in the heart failure work. At least 70% made at least one medication change, and at 12 months the intervention group were taking on average half an additional antihypertensive. The main changes in antihypertensive prescription were in terms of thiazides and calcium channel blockers, and this is largely that most of them were on an ACE or an ARB at baseline. In terms of side effects, there really wasn't much evidence that the intervention group had any worse side effects, other than in terms of ankle edema, which was presumably due to increased use of calcium channel blockers. In terms of costs, the intervention cost around £100 over and above the control, taking into account the cost of the intervention, the cost of consultations, outpatient appointments, etc. during the year. And in terms of cost effectiveness, we got an incremental cost effectiveness ratio of €22 per millimetre of mercury. And as you can see on our cost effectiveness plane, most of the results are in the top right-hand quadrant, which is what you want. In terms of the interview results, patients were generally positive about self-monitoring, and some were really quite surprised about the difference between their readings and the readings that they'd previously had at the surgery. The majority thought that the intervention was about right. However, clearly they hadn't really had experience of another intervention. There was failure in about 10% in terms of trying to train people at the beginning of the study. But we used an intention to treat analysis, so we included all of those. Patients generally didn't like taking medication but accepted that they had to, and all said that they took their medication regularly, and as far as we could measure, although we didn't use a particularly objective measure, but on self-report the adherence was high. Patients were more comfortable about making medication changes if their blood pressure was very high, as opposed to it was just above target, when they became rather less keen to change things. So the bottom line for our trial was that we showed that self-management and telemonitoring significantly reduced blood pressure, probably due to increased medication use, and was cost-effective. So how does this fit in with the literature? Well, last year, Boney produced a systematic review with 12 studies in it, showed that on average, interventions, including telemonitoring, reduced blood pressure by pretty much the same amount that we got in our trial. In the few trials that used ambulatory monitoring, there was less effect, but I think that may be the fact that there were only 3 comparisons there. And again, the evidence appears to be better drug titration is driving these results. There was significant heterogeneity between the trials, which just raises slight alarm bells. So in conclusion, just feeding back to a physician is not enough. Telemonitoring does allow promotion of the doctor-patient partnership. It allows more information about what the blood pressure is. However, one needs to be careful that you don't overload physicians. It's not clear yet whether the best thing to do is to give them rolling averages or quite how to produce the results, but clearly none of us want 100 sets of blood pressure results per patient in our inboxes. Feedback's possible. Carer burden, I'm not sure that we've shown one way or the other about that yet, and we've shown that there is better control comparing our results with our previous trial of self-monitoring alone. Just like to acknowledge the rest of my team, some of whom are pictured here, and our funders. Thank you very much.
Just before you were finished, he actually turned out to be Dr. McManus now, not Dr. King. All right, there's time for one or two questions from the audience. Please. Okay, there are not questions. I'll start off then. Did you monitor any other changes in there? For instance, their other healthcare behavior, like, did they also take their statins better, or how was their lifestyle behavior? And did you look at whether their whole risk profile changed as because obviously it's an open study, as we should do this. It's open, obviously. But did you look at it or not? And what were the results?
We didn't look at the risk factor data separately. We did look at, or we tried to look at lifestyle factors. We couldn't really find any difference between the groups, which we think was probably because we weren't measuring them very well. We're doing a further study now where we're using diaries to try and capture more subtle changes in lifestyle factors.
Because I guess you could expect either way, right? Either saying, my blood pressure's fine, so let's forget about the rest, or maybe they're being, probably stimulated to also change their lifestyle behavior.
Yeah, in our previous study, we did find a reduction in weight in the intervention group with self-monitoring, which does suggest that perhaps diet and exercise were being improved.
Okay, thanks. You wrap it off.
Okay, thank you very much to all of our speakers. We very much look forward, Professor Köhler, to the results of the TIMHF-2 trial, which looks at high-risk patients and differences in rural versus urban areas. Thank you very much, Professor Cleland, who put his case forward to shift from the crisis detection to health maintenance. And thank you, of course, Professor McManus, for your very interesting results and the mixed method study, which is something that I think we should promote in health research a lot more. Thank you very much. Have a great Congress.